and I am going to teach you on neonatal reflexes and reaction. First of all, I would like to take this opportunity to thank Dr. R.K. Mudgil and the team of HCAP for giving me this platform to tell you on the topic of primitive reflexes and reactions, as I told you earlier. So you must have heard of reflexes before, but today we are going to see the primitive reflexes. In the previous two sessions, you have learned about the treatment techniques, like you have learned about soft tissue releases and you have learned about PNF techniques. But here I am going to tell you on the assessment technique, which is an important factor in the field of physiotherapy. As we don't assess correctly, we won't treat correctly. So here we are going to emphasize on the reflexes which are present in the neonates or the young borns. All of us have experienced at one point of time in our life that whenever we touch some hot object, immediately what we do? We move our hand away. Or whenever a doctor taps the knee, involuntarily our leg moves forward. So what are these? These are our automatic actions, which are called reflexes in scientific terms. So here we are going to see what are primitive reflexes first. So these primitive reflexes are involuntary movements or actions, but they begin in early gestational weeks. Early gestational weeks means that they are appearing in your intrauterine life. When the fetus is in the womb and is developing, that time only these reflexes starts to appear. So these reflexes usually appear in 25 to 26 weeks and are fully present at birth in full-term newborns. Now these reflexes can occur spontaneously as a part of their normal activity. Like we have a reflex named ATNR, Asymmetric Tonic Neck Reflex, in which whenever the baby is turning the head to one side, what we are going to see? We are going to see the involuntary positioning of the baby into this position. So the face side extremities are going into extension, whereas the occipital side extremities are going into flexion. So this is a part of the spontaneous actions that we are seeing in response to some positioning of the baby as a part of his routine. Whereas for the elicitation of other reflexes, we need certain stimulus to bring out the actions in a baby. Okay. Now these reflexes are also age appropriate. Age appropriate means that they are going to appear at a certain age and they are going to disappear at a specified age. And they also, these reflexes are also closely related to the normal motor functions of these infants. So they actually are very important in the development of the baby's motor system. However, when they disappear incompletely. Now, what do we understand by incompletely? Means that in the due course of the development, these reflexes disappear. Okay, but in the adult life or in the later life, when the child is growing, so if the child or an adult suffers from injuries like you can say stroke or head injuries, so these reflexes can appear back. Okay. So as the CNS matures, as the higher mental centers matures during the course of growth and development, these reflexes subsides or disappears or integrates. But in the due course of time, due to certain higher lesions, they can always have a chance to reappear back. And that's why we say that they disappear incompletely. I hope I am making sense. And in between, sorry, I am taking a break from the topic, but I want to emphasize that please try to understand what I am trying to explain to you, because we'll be seeing the explanation and the elicitation techniques of each reflexes. So try to understand me first what I'm trying to tell you, and then it is always welcome that you can ask questions, and if the time permits, I'll take up the questions in the last few minutes. But if there is some issues that I won't be able to take the questions, then you can always revert me back on my WhatsApp number. Okay, so now coming back to my topic, I was telling that these neonatal reflexes are normal. So why do we need to check it? But these neonatal reflexes has a normal response also, but they have an abnormal presentation also. And when we say they have a normal response, so these normal responses are also variable, but that variance should be in the meaningful limit. Okay, meaningful limit means that it has to be within the neurological capabilities of that stimulus or for that infant. Okay, that is normal neonatal reflexes. And how it can be abnormal? So if we have to see that the reflex is giving an abnormal response, so that will be called abnormal if the reflex response will be persistent, or it would be weak, or it would be asymmetrical on both the sides, means giving different pictures on both the sides, or it is vigorous. So with these kind of presentation, we can link these responses as neurological impairment, and this neurological impairment can be seen in full-term infant, which is of a lesser chance, and specifically in preterm and high-risk newborns. Okay, and according to the current evidences, we have the persistence of these reflexes if beyond 5 to 6 months, then they are obviously and specifically related to your neuropsychiatric disorders. Now, what are the purpose of these neonatal reflexes? We say that everything has some function. So yes, even these neonatal reflexes or primitive reflexes has certain functions in the initial period of the infant's life. They are necessary for the nutrition of the baby. The primitive reflexes serve the function of protection for the baby. They also serve the function of survival for the baby. And in due course of lifetime, they also form a base for learned complex movement for the baby. Now, coming to the classification of these reflexes can be classified according to the region which is actually helping them to evolve. Okay, so we can say how they are being originated or mediated. So if we talk about the classification of these reflexes, so these reflexes are classified like automatic originated, spinal cord mediated, or you can say brainstem mediated, or midbrain mediated, or cortex mediated. So as the infant is born, he or she might be having some reflexes which are automatic or spinal cord mediated or brainstem mediated. And as the child grows, these lower centers mediated reflex integrates when the higher centers or the cortex controls. So after the higher center come into the picture and becomes or evolves in size, then the cortex takes over and takes the function in the form of reactions. Okay, so first we had reflexes. They disappear over few months, say 6-7 months, and some reflexes also integrates by 9 months. And after that, by 6-7 months, by some of the reactions comes by 2 months, 3 months. So in the later course of time, after 3 to 4 months, we have the cortex coming into the picture, gradually taking over the function of all these higher lower centers and gains control over the body. So now we are going to see the individual reflexes, the stimulus that we are going to give to the baby and the response elicited. Along with that, we are going to have a look on the time of appearance and integration and what these persistence will lead to. Okay, so coming to the first reflex, which is the rooting reflex. It is also a survival reflex. It is responsible for good feeding of the neonates. So now for this, what we have to do, what stimulus we are going to give? We are going to stroke from the corner of the mouth towards the same cheek. So you have baby in front, you are stroking from the corner of the mouth and stroking to the same side of the cheek. Now what response the baby is going to give? There will be protrusion of the tongue. You may find slight protrusion. You may not find complete protrusion of the tongue coming out, but you may see that the tongue is coming and touching the lips. And there would be turning of the head to the same side. Okay, so the stimulus is this and the response is this. Okay, it appears around 28 weeks of gestation and it remains till 3 months of age. Now, this reflex is the survival reflex, as I told. So, why this is so? This is because this reflex helps the baby to find the nipple for breastfeeding in the initial few days to months. Okay, and if it persists, it interferes with the oromotor development. Okay, why? Because if the baby is going to be stroked with anything, the oromotor muscles, it is going to give response in a specific pattern. So it is going to affect with the oromotor development and midline control of head. Our second reflex is sucking and swallowing reflex. It is also a survival reflex and is seen in the initial few months. For this, we have to give the stimulus in the form of tactile touch inside the baby's mouth or pressure stimulus on the lips. So either the therapist has to have a gloved finger for this. Okay. So what you are doing, either you are touching the lips with a pressure or you are giving the stimulus on the tongue inside the baby's mouth, and in response what do we see? That the baby closes the lips and starts sucking movement rhythmically. So you will see the movement of the lips and the mouth in a suckling manner which is rhythmic in fashion. Okay, so you can very well understand by the name itself that it helps the baby to suckle on the milk or on the breast, and its onset is from 28 weeks and it disappears by 2 to 5 months of age after birth. Does not mean that after 2 to 5 months of age the baby cannot suckle, but the reflexive movement disappears and it becomes a voluntary effort by the baby. Then our next one is palmar grasp reflex. So in that the stimulus is the tactile pressure that we are going to give from the ulnar side at the metacarpophalangeal joint. So what we are doing, we are stimulating like this, or you are just stimulating like this. Tactile pressure is being given, or you can have the stroke also. So the response occurs in 2 phases. In first phase, the baby grasps the therapist finger. Okay, the baby grasps the therapist finger, and in second phase there is sustenance of that flexion and adduction of the finger. So when you are stroking or giving the pressure like this, the response is going to be this. This is the normal responses that I am telling all you. Its onset is from 23 to 24 weeks of gestation and it disappears around 4 to 6 months of life. If it persists, it interferes with voluntary grasp and release of object, because whenever you are trying to hold something and if you touch something here, the grasp and the automatic release, the voluntary release of object is affected because the baby is not going to release due to the persistence of this reflex. And along with this, the baby is going to have affective protective reactions. Protective reactions we are going to see in detail later on, but in protective reaction we need open hand to stabilize our body on something. Okay, so the baby is not going to have open hand, so that's why the protective reactions are going to be affected. The next we have is plantar grasp reflex. For this we need to give tactile stimulus at the metatarsophalangeal groove on the plantar aspect. Like we did for palmar grasp, we are going to do the same procedure in the lower limb on the sole, and the response that we see will be curling of toes. It appears around 25 to 26 weeks of gestation and it remains up to 9 to 12 months of age. If it is going to be persist, then it will pose hindrance in walking, standing, weight shifting and balance, because with the curled toes, the baby cannot stand and walk effectively. The next we have is the traction reflex. So for that, you can have the baby in the palmar grasp position itself, or you can have the baby in lying position. I'm going to demonstrate you with my model what I had in house. So suppose this is the baby, and what we are going to do, we are going to hold the arm and pull the baby to a sitting position. So what we are doing, we are giving the traction to the shoulder and trying to pull the baby to a sitting position, but we are not pulling it completely. Okay, and what response we are going to see? We are going to see the flexion of the shoulder, flexion of the elbow, of the wrist and finger, and the baby tries to come to the sitting position towards the therapist. Okay, this appears around 28 weeks of gestation and remains up to 2 to 5 months of age. Next we have flexor withdrawal, which is a protective reflex. In this we have to give the noxious stimulus. It has to be noxious, means it not to be painful, but it should not be a superficial touch. It has to be a pressure stroke over the lateral border of the sole, like we stroke in case of checking for the plantar reflex. The same stroke that you have to give, and the response will be, there will be dorsiflexion of foot, extension of toes, hip and knee flexion. Now you will think, why extension of toes? Extension of toes ideally represent your upper motor neuron lesion. But in infants or babies up to 2 years of age, the baby does not have complete myelination, or myelination of the corticospinal tract is being going on. That's why they have extension of toes and fanning of other toes, and it is considered normal till 2 years of age. 1 to 2 years of age is the ideal time which is in which it is considered normal. Okay, so it appears around 28 weeks of gestation and disappears by 1 to 2 months of age. Similarly, if it is going to be there for a prolonged period, then it hinders with standing, walking, weight shifting. Next, as I told you, Babinski reflex, which is considered normal here. Otherwise, for the adults or with the children after 2 years of age, it is an abnormal sign which indicates your upper motor neuron injuries. So, the stimulus is tactile stimulus or pressure stroke over lateral border of sole, and in response we see fanning out of toes with great toe extension. Okay, it appears around 27 to 28 weeks of gestation and may be present up to 1 year. Next we have crossed extension. For this also you have the same stimulus, that is the pressure stroke over sole of foot, and you have to hold one leg into extension. Now we have holded the stimulated leg into extension. So what we are going to see response on the non-stimulated leg. So in that we have the flexion of the hip, adduction and then extension into the of the same leg, and its onset is from 28 weeks of gestation and it disappears around 1 to 2 months of age. Without mentioning, if it persists, it interferes with standing, walking, weight shiftings. Then we have primary standing reflex. So here the baby is in vertical suspension. Now to demonstrate what is vertical suspension, what we have to do, we have to take the baby or the infant and hold the baby under the axilla. Now this position is your vertical suspension, and what we are going to do, we are going to give the tactile stimulation by touching the sole of foot to the flat firm surface like this. I hope you are able to see this. So we are going to do this, and in response what we are going to see that the baby is going to put weight and do partial extension of the knee to put partial weight on this limb. This is primary standing reflex. It appears around 35 weeks of gestation and disappears by 2 months of life. Its persistence interferes with standing, walking and weight shifting. Next we have stepping reflex. So here also we are vertically suspending the child. The stimulus is same, you are touching the sole of the baby, but here you are tilting the child anteriorly. Okay, so in the first one you are just stroking the sole, here you are also tilting the child. And what the baby is going to do, the baby is going to flex this leg. This baby cannot flex, so the baby is going to flex that leg and extend the opposite leg. Okay, so flexion of this one and extension of the opposite one, as if the baby is trying to take a step. Okay, it appears around 37 weeks of gestation and integrates at 2 months of age. And it also, if persists, interferes with standing, walking, weight shifting and the smooth and coordinated movements of lower extremities. Now the next one, these are all primitive reflexes. We have not yet touched the reactions. Okay, so these are primitive reflexes which are appearing in the gestational period and disappears by 5 to 6 months, mainly 2 months of age. So next we have placing reflex of arm. For this, the infant is suspended horizontally. So now I'll show you how the infant is suspended horizontally. It will be like this. So the infant is suspended horizontally. Now I have to take my doll little down, and the dorsum of the hand is touched against the surface. Okay, so the dorsum of the hand is touched against the edge of the surface or the edge of the table. And what the response will, that the baby will do shoulder and elbow flexion to place the arm on the table, followed by extension to bear partial weight. You must understand that in these reflexes there is only partial extension that is taking place, and baby is able to put only partial weight. No complete weight is transmitted to the extremity. It appears around 37 weeks of gestation and disappears at 2 months of age. Similarly, we have placing reflex of leg. The baby is in ventral suspension. Okay, or you can say vertical suspension, and you are touching the dorsal aspect of foot to a surface. Okay, so the baby is in vertical suspension and you are touching the dorsal aspect of foot like this. Initially in two reflexes, standing and stepping, we were touching the sole, but here we are touching the dorsal aspect of foot to a supporting surface. And in response, we are going to see hip and knee flexion. Okay, so the baby is going to perform hip and knee flexion, and the baby is going to place the leg on the table, followed by extension to bear partial weight on it. This is the placing reflex, and it appears around 35 weeks of gestation and disappears by 6 months of age. Next we have Gallants reflex. Gallants, and in this the baby is in prone suspension. So the baby is like this in prone suspension. This is suppose the midline. So you have to take 3 centimeter lateral to the midline, and you have to stroke from the 12th rib. Here you cannot have the demarcations. So you have to stroke from the 12th rib to the iliac crest, and in response you will see the curving of the trunk to the same side of stimulation. It appears around 32 weeks of gestation and disappears by 2 months of age. It persistence results in the faulty development of sitting balance and can also lead to scoliosis. Next we have Landis reflex. In this, the baby is held in prone suspension or ventral suspension. So in ventral suspension, what you have to do, you have to place your palm like this and you have to hold the baby in this position. Okay, so this is the ventral suspension or prone suspension where you have supported the baby on the palm of your hand. Now if the baby's head is flexed or extended, then we have to observe the position of the other parts of the body. So when the baby head is flexed, we are going to see the flexion response in the upper extremities and lower extremities along with the spine. Whereas when the baby's head is extended, we are going to see the extension response of the lower limb and the upper limb like this. Okay, fine. And it appears around 2 to 3 months of age and disappears by 12 to 24 months of age. Next we have Morose reflex, which is brainstem mediated automatic response. For this, we have to take the baby in supine position, okay, and you have to flex the head. Flex the head. So ideally, the positioning is to be like this. From under the scapula, you have to hold the head into 30 degrees of flexion and suddenly drop the head. Okay, be careful not to hurt the infant. So in response, what we will see rapid abduction and extension of upper limb with opening of hands. The hands are open, followed by slower adduction and flexion component. Okay, so you have rapid abduction and extension with opening of hands, followed by slower adduction and flexion. Along with this, infant will cry. Majority of the time, the infant cries with this because it is a kind of a protective reflex. So infant is scared of fear of falling, and that's why the infant may cry. It appears around 28 to 32 weeks of gestation and this appears by 3 to 4 months. And if persist, interferes with eye-hand coordination and visual tracking and balance reactions. Next we have startled response. So for this, what you have to do, either you have to tap on the sternum. The baby has to be in lying position. Here I am showing it in this position. The baby has to be in lying position. Either you are giving a tap on the sternum or you are giving a loud noise like this near the ear of the baby. In this also you have the same response as Morose. The only difference is in the initial Morose you had extension of elbow. Here you will have flexion of elbow with hand closed. So the difference between Morose and startle is Morose had extension of elbow with open hand and here you have flexion of elbow with closed hands. Okay, abduction and adduction phases are like in Morose. It also has the same time of appearance and disappearance as Morose and has same effect if persist. Now we have ATNR. As I told you earlier that when the baby is moving his head to one side, then there will be extension of the face side extremities and flexion of the occipital side extremities will be there. Okay, this reflex is helpful in dissociating the body into two halves. Pattern of asymmetry is generated between the right and left half. So the baby will learn the asymmetrical patterns, or the baby will learn that the body can be dissociated into right and left half. The baby also learns hand regard because baby can watch his own hand performing the things, and with that baby can also learn to do reach out activities. It appears at birth and integrates at 4 to 6 months, but if it interferes, it alters or it hinders with the rolling capability, turning to sidelines, hand to mouth activities, midline use of hand, and bilateral use of hand simultaneously. Next we have symmetric tonic neck reflex, which is also called STNR. The stimulus can be when the baby is taken into a sitting position or kneeling position. The change in the position of the head, okay, the change in the position of the head into flexion or extension will affect the tone or posturing of the upper extremities and lower extremities. So if the baby is going to have extension of the head, then the baby is going to have extension. When the baby is going to have extension of the neck, baby is going to have extension in the upper limbs and flexion in the lower limbs. Okay, or the baby can have increase in tone. If we do not see the exact movements, exact extension or flexion, then we can see the increase in that specific tone. Okay, and when the head is flexed, it is going to be flexion in the upper extremities or increase in flexion tone in the upper extremities, and extensors or extensor tone in lower extremities. It appears at 2 to 3 months of age and disappears by 9 months. And if it persists, it interferes with quadruped positioning, crawling, and the use of hands in sitting position. Next we have parachute reflex, which is a protective reflex, and this reflex appears early but it persists throughout life. Okay, so it appears early, like around 6 to 9 months, and it persists throughout life because it is a protective reflex. Even as the child grows or we become adults, we need protection for ourselves, so it is going to persist. So the baby is in ventral suspension and suddenly projected towards the floor. So suppose this is the baby and the baby is in ventral suspension. Now what was ventral suspension or prone suspension? Was like this, okay, and the baby is taken to a surface. Okay, so what the baby is going to do when the baby is suddenly projected to a surface, don't hit the baby with some surface, okay, and what the baby is going to do, baby is going to do extension and abduction to spread the upper extremities to avoid being hit. Okay, so this is the protective reflex. When you suddenly project the baby to a supporting surface, what the baby is going to do, the baby is going to move away to spread, to do abduction and extension. Abduction and extension allows movement away from the surface. So it is a protective reflex. Now we have the last reflex, which is tonic labyrinthine reflex. It is very essential. We treat patients, even adults with neurological diseases, or infants, or our children with CP are also treated by implementing this reflex. So it is tested in 3 positions: supine, prone, or sideline. And by putting the baby in different positions, we see the dominance of different type of tone into the baby. So when we put the baby into prone position, you have to simply put the baby into either prone position or supine position, or you have to put the baby into sideline position and just see the response. So whenever the baby is put in supine position, the baby is going to have extensor tone dominance. Okay, so if the baby has baby is a flabby or floppy infant syndrome is there, so you can put the baby into supine position so the baby can have extensor tone dominance. Okay, if the baby is put in prone position, the baby is going to have more of flexor dominance. So if a child is there who is having extensor thrust, or opisthotonus, which is increased in extensor tone, so such kind of babies or such kind of adults with neurological diseases can be put into prone position so that they can have the flexor tone dominance. And when we talk about sideline position, so when we put the baby into sideline position, the lower half, the lower upper extremities and lower extremities will have extensor dominance, and the upper half, the unsupported upper extremities and lower extremities will have flexor dominance. Okay, it appears at around birth and disappears by 4 to 6 months. But in case of neurological diseases, or in case of cerebral palsy, or in case of any head injury kind of problems, this reflex can always appear back, and it interferes with standing, sitting and other developmental milestones. So that was for the primitive reflexes. Now you may ask question, ma'am, why do we need to actually check these reflexes? So it has been researched with clear-cut evidences that if the integration of these reflexes are not being progressed properly, okay, if the integration of these reflexes are not progressed properly, then the child may demonstrate poor motor abilities. Okay, poor motor abilities means in terms of upper extremities also, in terms of lower extremities also. If we talk about our fine motor abilities, if we talk about catching and throwing abilities of a child, if we talk about the running potential, cycling potential, walking potential, their maintaining balance, all these activities, all these motor abilities will be affected. So you can very well see that if an infant is not having the integration of these reflexes, then the baby or the child in the later life is going to be very clumsy. This is not all. The child is also going to suffer from different psychomotor difficulties. The child is also going to have behavioral issues. The child is also going to have learning difficulties, and because of that, the child is going to be academically backlogged. Okay, the child is going to suffer in the school. Okay, so it actually just the primitive reflexes, non-integration is going to affect the whole life, the psychomotor abilities of the child. And my point here is I'm emphasizing on these reflexes because I feel that these primitive reflexes should be handy and should constitute a part of each and every standard examination which has to be done at periodical level. Okay, before entering into the school, at the end of 6 months, at the end of 1 year. So it has to be periodic evaluation, and therapist has to evaluate. A physical therapist need to know these reflexes, their normal responses, abnormal responses, so that we can delay these psychomotor problems, and found if found, we can intervene from the very beginning to make the child a successful person, to not to make him suffer for his learning difficulties, for his behavioral issues. We always label the child as difficult child, but we do not understand that what problems which is not under his control, it is from his makeup. Okay, it is because of his persistence of those primitive reflexes which he or she may not be knowing. So we have to make the parents understand these reflexes, the consequences, and for that we need to know what these reflexes play a part in the normal development of a child. So now coming to the, I'm not going into the detail of the treatment approach of this, which is actually by the therapy reflex integration method. Okay, we have different approaches for it. We can use neurodevelopmental therapies also for the treatment. So that does not constitute the part of my talk today. Maybe sometime later we'll talk about it. Okay, so first we need to know how to assess this. Now coming back to the reactions which I told, when the child grows and become mature, so these reactions come into picture. So when we talk about reactions, the reactions can be writing reactions, positive supporting reactions, protective reactions, and equilibrium reactions. Some of these reactions disappears by 5 to 6 years of age, and some of these reactions persist throughout life. Means it will be persisting in you and me also and will be for our benefit. Okay, like our protective reactions, our equilibrium reactions, our staggering responses. So these reactions are present in us and it is for our safety and purpose. Okay, so now coming back to our writing reactions. In writing reactions, we have three type of reactions: vertical writing reactions, horizontal writing reactions, and rotational writing reactions. Now first we will see the vertical writing reactions. So when we talk about vertical writing reactions, we have labyrinthine writing reactions and optical writing reactions. In both the reactions, the stimulus is same. The only difference is in optical writing reaction, we do not blindfold the child. Blindfold means you have to occlude the vision. So in optical writing reaction, we do not blindfold the child, whereas in labyrinthine writing reaction, we put a strap around the eyes and we blindfold the child. Now what is the stimulus? That we vertically suspend the child from under the axilla and tilt the baby 30 to 40 degrees anteriorly, 30 to 40 degrees posteriorly, or 30 to 40 degrees sideways. Okay, and we hold the baby in that tilted position for 3 to 5 seconds. So now what is the response? We are going to see that when you have tilted the child is going to orient the head into a vertical position. When you have tilted the child backward, the child is going to orient the head into a vertical position. When you have tilted the child to a sideways position, the child is going to align the head into vertical position. Okay, and these reactions appears at around 2 months of age and they persist throughout life. Next is your body writing reaction. So body writing reaction means that you are going to place the child on a flat firm surface like this, and when you put the baby in this position, the baby is going to do this movement of the head. The baby is going to orient the head in the vertical position. Okay, it also appears by 2 months of age but disappears by 5 years of age. Next we have horizontal writing reactions. Horizontal writing reaction, we have Landis writing reaction, which is same as that of Landis reflex. Okay, what we have to do? We have to horizontally suspend the child from the chest. Okay, so what we are doing? We are horizontally suspending the child from the chest, and what we are seeing? We are seeing the response of extension into the head followed by the whole body going into extension. This reaction appears at 2 to 4 months and disappears by 2 to 2.5 years of age. Next we have rotational writing reactions. It is of two types: neck writing reactions and body writing reaction. So in neck writing reaction, the therapist is on the neck side. Okay, so suppose this is the baby. You are rotating the head to one side, and what response we are seeing? Segmental roll of the body to the same side of the head roll. Okay, and next was your body writing reaction. In that we are taking the limb and rotating it to the one side. So to this stimulus, what we will see? Spontaneous rotation of the upper body to the side of leg roll. It appears at 4 to 6 months of age and this appears by 5 years of age. Next we have some supporting reactions. So in supporting reactions of arm, we place the child prone on flat firm surface. So in response to this, child will do head extension and then progressively weight bearing on forearm and then on hands. So this is the positive supporting reaction. When you make the positive supporting reaction of legs, to be tested, you have to hold the child vertically and touch the sole of foot as you were doing in reflexes. Okay, but now the child can bear her or his proper full weight on both the soles, and this reaction appears around 6 to 9 months and persists throughout life. Then coming to the protective reactions. In protective reactions, we have placing reaction of arms and legs, and these are visual placing reactions. Okay, so in this you have to bring the child closer to the table, and in response to this, the child is going to do extension of the extremities and is going to withdraw from that surface so that doesn't get hit or hurt, and is going to bear full weight on it. Okay, and these reflexes are also going to persist throughout the lifetime. Then we have protective extension of arms. So whenever the child is in sitting position and you are going to displace the child forwards, backwards or sideways, the child is going to do extension and abduction to the same side of displacement. Okay, and these reflexes are also, these reactions are also going to persist throughout lifetime. Next we have downward parachute, or which is the protective extension of the leg downwards. So now what we have to do, we have to hold the child and bring the baby downwards to a supporting surface. So if this is the surface, you are going to like this, and what the baby is going to do, baby is going to do abductions and knee extension and dorsiflexion to avoid being hit. It also persists throughout life. Then you have protective staggering. So protective staggering now is tested in standing position, and we are displacing the child in the directions forward, backward and sideways. And what the baby is going to do, baby is going to do abduction of the displaced side extremity to prevent his or her fall. Now we have last, which is the equilibrium reactions. So equilibrium reactions are being tested on a tilt table. Okay, and the child is being placed in different positions like supine, prone, sitting, standing, quadruped. You put the patient in different positions on a tilt surface. Any surface can be taken, verbal board or any wobbly surface can be taken, and you have to slowly tilt the tilt board so that the baby is exposed to a dynamic force. And in response, what do we see? We see the lateral flexion towards the elevated side. So suppose if you are tilting the baby on a tilt surface like this, the baby is going to curve to the elevated side and is going to do abduction of the extremity on the elevated side, and sometimes we note the trunk rotations also. Okay, and these equilibrium reactions are also persistent throughout life with different time span of their originations. I hope this was the basic reflexes and reactions which are important and forms a critical part in the assessment of a newborn or an infant, which dictate the later psychomotor abilities of a child. Sorry, due to time constraint, I was not able to take any of the questions. I do understand that taking up the question, answering your queries is very essential, but I had short time and I had quite a bit to explain you. But feel free to contact me on my WhatsApp number. My WhatsApp number is 9896554089. Definitely I'll reply to each one of the questions which will be asked to me. Thank you. Pleasure having you. Thank you, Dr.